We're good. Yeah. Amazing. So basically, my name's Donal Wallace. I'm a GP, and I'm an assistant professor in general practice working here in the department. So you're all very welcome. I'm absolutely delighted to be hosting Dr. Duncan Shrewsbury under the TCD Faculty of Health Science Visiting Professor Fund. And it's my pleasure to introduce you to them this afternoon. So we're very grateful to the Academic Primary Care Collaborative for this opportunity for Duncan to speak to you. So I'm going to hand you over to Imelda, who's going to bring us through a meditation before we get started.
Thank you. Good afternoon, everybody. I'm just going to start with a little short reading, and I'm just going to do the bells for like quietness time. It's a short meditation that we do in Oncuson. It's part of our ethos there that all our classes begin with an opening circle. So Oncuson is an adult education centre and an early years centre in Jobstown, Tala. And it's great to be here today. We have our University of the Third Age group in attendance, and some other of our students are online. So I'm a community rep for the Academic Primary Care Collaboration here. So thank you. So our reading today is, we live in one another's company for a reason. Each one of us has unique gifts, but our gifts can be a burden if they are not shared. Our own growth and development depend partially on the contributions of others. We live better when we share in the presence and talents of others, just as others benefit from our positive involvement in their lives. Thank you, everybody, and hope you all enjoy the talk. Thank you.
Thank you. Thank you. Thanks, Melda. So I'm just going to give a little bit of background to Duncan. So Duncan is a GP in Brighton and academic at the Brighton Sussex Medical School. In general practice, Duncan leads for the care of trans and gender diverse patients, as well as mental health. And urgent care, sexual health and substance addiction in different parts of England. So prior to qualifying in medicine, Duncan was a biology teacher and developed expertise in supporting adult learners with learning difficulties. And this fueled their passion for education, consequently leading them to complete their master's and then their PhD in medical education. So much of Duncan's research has been focused on learner support, inclusion and curriculum design in medical education, and their clinical research has focused on understanding and addressing health inequalities faced by marginalised communities, with more recent work focusing on trans and gender diverse communities. Duncan is also the co-chair of the Society of Academic Primary Care in the UK, and very impressively, Duncan was recently awarded the highest level of professional recognition from the Higher Education Academy, the Principal Fellow status. So we're very fortunate to have Duncan with us this week. They've had a very exciting and busy schedule during their various meetings with staff members and students at TCD, and I've certainly learned loads from them during the week, and I'm sure this lecture will be very beneficial to you. So the title of Duncan's talk is Inequalities and Inclusion in Healthcare, Understanding and Meeting the Needs of LGBT+ Communities. And just to mention, all the slides from today will be shared on the Faculty of Health Science website. So as well as the University of Third Age group, we're also joined by a number of senior cycle students from local secondary schools in the Tala area. So you're all extremely welcome. And given the diverse group of attendees, I'm sure we'll have a very interesting Q&A discussion at the end of the talk. So without further ado, it gives me great pleasure to introduce Duncan Shrewsbury.
Thank you very much, Donal, and thank you very much, everybody, for having me here today. It's been a real privilege to visit Dublin and TCD in particular. Everybody's been so incredibly welcoming and enthusiastic about something that's very close to my heart. So it's been an absolutely wonderful visit. As I go through the talk, if there is anything that springs to mind in terms of a question or anything like that, we do have some Q&A time at the end, but I welcome questions as we go along too. So if anything does spring to mind, do pop up your hand, and I'll try and keep an eye on the chat as well to see if any of our Zoom visitors also have any questions too. So, in this talk, I'll talk to you a little bit about what we mean when we're talking about the LGBTQIA+ community, and then introduce you to some of the specific healthcare needs that are unique to this community, before exploring why this might be, why there are disproportionate healthcare needs within this community, and then going on to unpick some of the barriers that are faced when trying to access healthcare. I think it's important to note that whilst we're in a learning space, I will be talking about some aspects of lived experience for this community that are maybe touching on some sensitive issues, including some of the violent crime committed against people within the community. If any of this makes you feel uncomfortable, do by all means please feel free to step out or let me know, or come and have a chat at the end, and we can work through some of the aspects, but hopefully it'll all come across as a sort of in a gentle learning sense. So first of all, what do I mean when we're talking about the community? Some of the abbreviations might be very familiar to you, but it also might be a bit confusing because sometimes you see different permutations of the abbreviation used, such as LGBT, LGBTQ, QIA, and so on and so forth. Just to be absolutely clear, it stands for lesbian, gay, bisexual, transgender, queer, intersex, and asexual. Intersex refers to a specific group of people who may have a genetic or medical condition that alters the appearance of their primary sexual characteristics. So we assign sex at birth based on the examination of a baby. Do they have genitals that look like they correspond with the vulva, like the external genitalia of the vagina, or do they have what looks like a penis and scrotum? And that is the primary sexual characteristic. So when we talk about primary and sexual characteristics, the primary is what genitalia appear like, and what we judge that to be based on at birth. And then secondary sexual characteristics is what we develop when we go through puberty. It is also important to know that sometimes the term gay is used to refer to both gay and lesbian, i.e. all homosexual relationships, but that term, or the use of that term, can be quite sensitive, and it was something that we've talked about in previous meetings where it can be a little bit confusing navigating what we do and don't use. As somebody who's masculine presenting, I would probably be a bit careful about using the term gay to refer to relationships that some of my lesbian friends might be in, for example, but I might pick up on the use of that if they volunteer the use of that term when referring to their relationships. Also, when we're talking about terminology, I've already mentioned that the Q stands for queer, and that's an example of a term that has been reclaimed by the community. It has pejorative origins as a slur against people within the community, usually used to refer to people who are deviant or other, or strange or different. And that term has been reclaimed to refer to a celebratory, inclusive way of referring to people within the community who do not necessarily identify as cisgendered or heterosexual. I will explain cisgendered in a couple of points' time. I've mentioned sex and how we assign sex at birth based on the appearance of the primary sexual characteristics, the genitalia that a baby has. And sex is used to refer to the more biological construct of whether somebody looks like a male or a female person. Gender identity is more the psychological or the social construct of manness, maleness, or femininity, and is usually heavily influenced by socialized norms ascribed to gender roles, such as boys liking tractors and guns and violence, and girls liking dolls and pink and flowers and that sort of stuff. So that's how the social construct of gender and gender identity is informed. But saying that one is very clear and biological and binary, one or the other, and there's this slightly more woolly concept of gender, isn't quite an accurate representation of just how complicated it is. I've already mentioned our community of intersex individuals, and it's important to note that out of all of the various different conditions they have, that might refer to about 1 to 2% of our population. So it's a small number, but a very significant number. And these individuals are a very good example where biological sex isn't clear and isn't binary. So when we refer to, or other people, I don't particularly refer to sex-based rights, but when you hear politicians and the social rhetoric about sex-based rights, which is rights that should be ascribed to, for example, protected spaces based on your biological sex, and there's a sad example in the UK at the moment where our Minister for Women's Inequalities has proposed a change in the wording of our legislation, the Equality Act of 2010, to refer to sex rather than gender. The assumption that that is based on is that sex is nice and clear and binary and very obvious. And we know that that's not the case. As I've mentioned already, in 1 to 2% of the population, we know that that will not be necessarily the case. People may not have XY chromosomes or XX chromosomes, or they may have ambiguous genitalia, or they may have the right chromosomes and the right appearance to their genitalia, but their genitalia might not function. And so how we define somebody based on their biology isn't as clear as we might be being told it is. And it's helpful to just remember that, because sometimes people really bang that drum quite hard, and it makes us think that this might be a nice, clear-cut, simple solution, but really it's a lot more complicated than they're letting on. I've mentioned gender identity, and gender expression is how somebody might choose to express their internalized sense of masculinity or femininity. As you know from the title slide, I use they, them pronouns, so I identify as non-binary, and I choose to express my gender identity partly through my physical appearance, what I wear in terms of clothes, such as my skirt. I made this myself, and also in terms of the language I use. So I try to be quite inclusive in the way that I refer to other people, as well as the way I refer to myself. And non-binary is under the same umbrella that you could consider transgender individuals, because the term transgender refers to anybody whose current gender identity does not align to that which they were assigned at birth. So I was assigned male at birth, and my gender identity now is a non-binary. And so thinking about that, I would fall within the dictionary definition of transgender. However, there are hierarchies everywhere in society, and even within marginalised groups, there are often hierarchies. And within the transgender community, there would be a perceived hierarchy as to whether you're really or properly or very trans or not. And so by virtue of that, and by virtue of the fact that I do still appear quite masculine, I would not necessarily be considered as much a member of the trans community as somebody else who may have gone through more processes, more steps towards their transition. I would say that one person's transition journey is very different from another's, and it doesn't necessarily mean that you have to have gone through a certain number of procedures or treatments or changes in order to be validly transgender, irrespective of the notions of hierarchy within different groups that I've just alluded to. So as well as transgender, you might have heard of the term cisgender. I know I've used it once already this afternoon. And cisgendered is the term that is used to refer to somebody whose gender identity is the same as that which they were assigned at birth. And these terms come from organic chemistry. If you've done chemistry, you might remember that there are some molecules whereby they have an arm sticking out at one side. And if they have another arm that sticks out the same side, that is a cis molecule. And if the molecule has an arm that sticks out the other side, that is a trans molecule. And that's why that terminology has been reappropriated when referring to gender identity. You may see transgender individuals referred to differently by different groups of people. And it's helpful to know that sometimes the different ways that transgender people might be referred to linguistically can allude to different thoughts, feelings, beliefs, and attitudes towards them. And a good example of this is the term trans man or trans woman, when instead of a separate word, like we can see illustrated here, which is to use the trans component as a verb to describe them as, say, just as you would a tall man or a tall woman, is when the word is contracted into or the two words are contracted to a single word. That is a technique to other that community and those individuals. They are no longer the same sort of species as other men or women, and they are othered through that linguistic device there, which can be a bit complicated and sound a little bit pedantic, but it is something that is intentionally used by some gender critical groups, which can be associated with quite significant pejorative attitudes towards trans people. So I mentioned my use of pronouns, and I think it's just helpful just to bear in mind what pronouns are and what we mean about them. And there's often quite a lot of confusion around them, especially when people like me use pronouns that we might assume are associated with a plurality of referring to people rather than in the singular. So in our language, we actually have 4 genders within the language that we use: masculine, feminine, neutered, and a common pronoun. Pronouns are a linguistic way of referring to an individual, usually in the singular, but we also use them quite frequently to refer to a group or plurality of individuals. And the way we use pronouns or choose not to use pronouns can allude to and speak to our underlying beliefs and values. So the fact that I choose to ask people their pronouns and share my pronouns alludes to the fact that I know that use of pronouns can be quite important to some people, and so I value that. And I sadly work with some people who, if despite having shared my pronouns, they still choose to use pronouns that they feel are otherwise appropriate for me, that tells me that they don't respect that aspect of my identity and that they feel otherwise, which can be quite hurtful sometimes when you know it's intentional. And the use of incorrect pronouns, yes, it can happen by accident. I certainly get a slip up and still use he, him pronouns when referring to myself occasionally. But when it's done in a repeated way, despite having requested other, it does imply that it is probably an intentional use, and there's an aggression in that. Just to make you aware of the different permutations of the different ways of using pronouns, we have the very obvious traditional he, him, his, she, her, hers, they, them, which is a way of referring to people in the singular as well as plural. For example, if somebody's left their pen over there, I hope they come back and find their pen. I'm referring to just one person, and it is very commonly done, although sometimes we forget about those examples. Just to add a little bit more complexity, you do find that some people use multiple pronouns, such as he, they, or they, he, and she, they, she. The order that people might use them in also alludes to something that might be important to them too, such as somebody who still identifies with some notions of masculinity, but like me using they, them pronouns, I don't, being non-binary, I don't identify with it, either orthodox masculinity or femininity. I don't see myself in either camp. I don't see myself on a spectrum. I'm somewhere in a cloud, kind of all over the place. Then there's also prefixes such as Mr, Mrs, Doctor, and so on and so forth. Some of them are gendered, and you can see neo-prefixes such as Mex, the MX, which is pronounced as Mex, as in Mexico. That is a gender-neutral prefix. And there's also the option of not using any pronouns at all, like my mum always used to say, who's she, the cat's mother? You can always use their actual name. So, just to give a little bit of context, we know that in the UK, from census data, there's around about 3 to 5% of the population, and in Ireland, 5 to 7%, which is a closer representation or reflection of what we see across Europe, of people above the age of 16 identifying as belonging to the queer community. And now that difference is probably reflective of a significant proportion of those questions in UK census data being left blank and unanswered on the returns. We know that as well as our patients facing inequalities when accessing healthcare, we know that our colleagues in healthcare too also experience discrimination and inequity whilst working in the healthcare environment. We also know from surveys and research done that medical students have a low level of confidence in feeling prepared prepared to help and work with diverse communities and have quite a significant level of concern and fear about getting things wrong and being ill prepared for that. We know that students want greater training, and we know that those who have more experience are better prepared to take a more holistic history and work with people in a more holistic way. Now, thinking about some of the specific healthcare needs of our community, you might traditionally have associated health inequalities in the queer community as being largely related to sexual well-being. And there are certainly greater concerns for things such as living with HIV within the community, although the greatest rates of transmission, so incidence of new HIV infections in the UK, is now more prevalent, more common in the heterosexual community than it is in the homosexual community. So the greatest rate of spread and transmission at the moment is not within the queer community. What we do find, though, is there is a much greater rate of mental ill health within the community, with a doubling of the burden of depression and anxiety, and a tenfold increase in suicidality within the community, especially within the trans and gender diverse community. Not only do our communities have greater healthcare needs, but we also find that they experience greater barriers to accessing healthcare. There's a significant proportion of people who don't even try to access healthcare for fear of experiencing discrimination based on their queer identity. And sadly, quite a significant proportion of people who do go on to seek healthcare do experience discrimination or prejudice based on their queer identity, with about a quarter of people having experienced some sort of derogatory remark and about an eighth of people having experienced their care being significantly altered and different because of their group membership. And sadly, about 10% have had their queer identity disclosed to other patients or to other members of the healthcare team when it hasn't been relevant to their care. And perhaps most egregious, at least in my view, is that 1 in 20 people who have accessed healthcare for something unrelated come away feeling that they've been pressured to access services that are intended to either suppress or change their gender identity or sexuality, otherwise known as so-called conversion therapy. Now, so-called conversion therapy is a collection of practices, some aligned to religious ordinances, others secular. And just to be really clear, a government independent funded review concluded after an absolutely thorough investigation, both of primary research, but also reviewing data and evidence available from other research, that the practices involved in so-called conversion therapy are not therapeutic at all. They have long-term lasting damage and are traumatic. And the sort of practices that they draw on are familiar to things such as exorcism, such as starvation from food or water, or electric shock aversion treatment. Now, as I mentioned, indisputably traumatic with long-term damage. And unfortunately, one sixth of people who have conversion therapy come away from it feeling or being under the impression that it was delivered or supervised by a healthcare professional. And this is contemporary data. And to illustrate that, or further illustrate that, in November 2021, the annual representatives meeting of the British Medical Association, a collection of doctors put together a motion to pass for to call on the government to advance their ban against conversion therapy. And the motion was passed successfully with a majority of 70%, but there was no abstention. 30% of our contemporary colleagues felt that conversion therapy had some sort of role in contemporary healthcare practice, which to me is really quite alarming and tells me we've got a lot of work to do to help people understand better what it involves and what damage it can cause. The UK government had promised to advance a legal bill to outlaw so-called conversion therapy practices, and they still have not done so, with the latest sort of caveat being that they would advance that bill with the exclusion of trans and gender diverse people. The British Medical Association, the Gay and Lesbian Association of Doctors and Dentists, and the Medical Schools Council worked together to create this charter, the UK Medical Schools Charter on so-called conversion therapy. Now, this charter calls for 6 actions from each medical school, and if you're interested in reading more about conversion therapy, the summary in this document is a really, really accessible and, importantly to me, shorter summary of all of the research, all of the various other government reports and papers. It condenses 80+ pages into 3 or 4 pages. So if you're interested and you'd like to read a bit more, if you Google for that charter, you'll be able to access a much more accessible summary. One of the important things here is not just to support the ban on conversion therapy and not just improve the education about what conversion therapy practices may involve and the damage that they can do, but also to encourage a more joyful representation of the queer community in teaching, assessment and research. Now, that joyful representation, it sounds a little bit abstract. What that means is essentially not just including the queer community in examples of, say, HIV treatment, or even just in relation to mental ill health, but also to depathologize their representation in the community and in teaching and assessment. And so one of the things that we've done at Brighton Sussex Medical School is look at how we diversify all patients who are represented in our teaching materials, not necessarily to say that somebody comes in and this is the condition that they've got. But for example, in our first year, when we teach our students about the development of children and their families, we have families now who have 2 mums or 2 dads, or adoptive families, just to help illustrate that there is much greater diversity than the traditional family that might have been set the template for previous years. So, I'm sorry, the graphic hasn't come out there, but why might the healthcare needs of this community be different? Well, there's a couple of helpful theories for us to draw on when considering why our community might experience greater rates of mental ill health and other conditions. There's something called minority stress theory, and actually the origins of this far predate the 2003 paper, but that's perhaps the seminal paper that helps illustrate and explain minority stress theory in its entirety. And to summarize it, we've essentially got 2 different kinds of pressures. The pressure from constantly being excluded or missed out of certain opportunities, and the pressures from trying to pass, so sociologically speaking, which it means to kind of hide or mask aspects of yourself. Passing would mean trying to appear and sound more like a cisgendered heterosexual man. And the constant effort exerted on trying to do that, or the constant chipping away at your self-esteem and sadness from being excluded from things, even though it might be quite low level, has that the fact that it's continuous and constant has a really long-lasting effect. And we can see this exerting an influence on very tangible biological things, such as your cardiovascular disease risk, such as your wound healing, which can take longer in people who have chronic low-level minority stress, and cancer survival. Another theory that's helpful to consider is that of adverse childhood experiences, otherwise referred to as ACEs. Now, we know that something like 60% of people before the age of 16 or 18, I can't quite remember which now, will experience 1 or more adverse childhood experiences. But we know that far fewer, only about 15% of people will experience 4 or more. And that 4 or more is a really significant threshold, because when people experience more than 4 adverse childhood experiences in their formative years, they then have very real, tangible differences on their chronic disease burden. So there's a doubling, but also with brain development. So there are observable differences in the development of brain structure and function in people who have multiple adverse childhood experiences in their background. And this has an impact on the way that they can form relationships and develop trust with people. And that influences how people might be able to access healthcare. We know from data in general practice that when we develop continuity with our patient, they get to see the same doctor again and again. We paint a bigger picture over that period of time, that we build that trust and that understanding. And they struggle to do that, and so often consult multiple different people, having much more disrupted and disjointed care. ACEs account for things such as abuse and neglect, different types of substance abuse within the family setting, disruption of family structure and witnessing violence in the home. But it's also important the queer community experience adverse childhood experiences significantly outside of the home as well, such as in the school setting, where there are greater rates of harassment, physical abuse and sexual assault, either from teachers or from other students. And even once they've survived childhood, the community doesn't necessarily feel safe. And I've included some specific examples from Brighton here, partly because it's often painted as a bit of a safe haven in the UK, a bit of a sort of capital for the queer community. And whilst there is a significant amount of inclusion in the Brighton community, there is still, sadly, a much greater rate in the last 4 years of hate attacks and hate crimes committed against people in the queer community. And this is reflected across the whole of the UK, with a 25% increase in the last 4 years. And sadly, in response to those violent crimes, we're seeing structural responses from society that excuse it or pardon it or even blame the victims. And this is very reminiscent of the same sort of language that's used when referring to violence against women. You might be familiar with the case for the tragic murder of Sarah Everard, who, a woman in her 20s in London, I think in the summer of 2021, murdered by a police officer. And the advice from the Metropolitan Police in response to that was to tell women not to go out too late, not to go out by themselves, and not to wear anything too provocative. It's the women's fault that this police officer decided to murder somebody. And the text that I have quoted there is from the closing statement from the Crown Prosecution Service, the team charged with the responsibility of seeking justice for the victim in the newspaper clipping above that, which was a consultant psychiatrist in Cardiff, who was, whilst he was out cottaging refers to when gay or bisexual men who have sex with men seeking erotic intimate activity with another consenting adult, usually in a public space, but usually sheltered. And he was in a well-known park in Cardiff doing exactly that. And two teenagers, a 17 and 19-year-old, tackled him to the ground and stamped on his head until he died. This was all caught on CCTV footage, and they were seen to be laughing throughout the whole time. And that is not mentioned in their closing statement. The Crown prosecution team said his sexual proclivities were to be his undoing. By him engaging in that activity, he rendered himself hopelessly vulnerable and was an easy target. There's nothing there about the evil and malice involved in the people who murdered him. So, some of the things to be mindful of. You might have heard of the term microaggressions, but what on earth does that mean? These are everyday slights, small, usually verbal cues, not always, though it can refer to body language, such as somebody being intimidating or making it difficult to access something or pass by. And the choice to either display that body language or the use of certain words is usually based on that individual's group membership. Now, in the case of somebody with diverse gender identity, it might be the use of inappropriate pronouns. But in other sort of examples, such as thinking about racism, for example, it might be the persistent questioning of, no, but where are you really from, kind of thing. Now, just to help illustrate some other points around inclusion in healthcare, I'm going to talk us through 3 sort of simplified case examples. And hopefully through that, I'll be able to explain a few other sort of related concepts. Now, the first one, our computer software in general practice tells us that we're seeing a 62-year-old person with a male gender marker, and they have a name which could be quite ambiguous. In this case, we've chosen Chris. And you go down to reception, and somebody who looks like the picture in the box to the left stands up. And because Chris is an infrequent consulter, I'm not familiar with them. I've not met them before. And your first thought is, goodness, have I got the right patient here? But asking them in the waiting room is not necessarily the best place to do it. So you go back to your consultation room, and a nice little trick is just to ask to check their date of birth to make sure you've got the right notes up. You have got the right notes up in this case, and sometimes that can be a helpful way of prompting a conversation about checking whether Chris would like to update any of the record. Sometimes patients aren't aware that they can change their name on their GP record without having gone through deed poll or anything like that. And just making that clear can sometimes be really helpful at this sort of stage. But Chris still goes by the name Chris, and doesn't want to change anything on their medical record, although is happy for you to include what pronouns they use in their otherwise known as field. And during the consultation, Chris explains that although she has lived her life in the appearance that she has turned up to today, so she has socially transitioned, she feels that that's not enough, and actually she needs help because she is transgender and is still feeling significant dysphoria, gender dysphoria, despite the social transition efforts she's made. Now, I mentioned earlier that one person's journey is very different from the other, and as well as things like makeup and hair growth and things like that, you do find that sometimes people alter their appearance through having top or bottom surgery. Top surgery usually refers to either having a mastectomy or breast augmentation through implants, and bottom surgery usually refers to alteration of appearance of genitals. Nobody needs to have gone through any of that, though, in order to seek help. And by the time they come to you as a clinician, they've usually done quite a fair bit of soul searching and homework already anyway. And so if somebody comes to me and says, I think I'm struggling with my gender identity, it's not for me to question it beyond that. It's for me to say, how can I help? And the first thing that I can usually do is refer them to one of the local gender services. There's 7 in England, and all of them have on average around about a 4-year waiting list. I know that there's a gender service in Ireland, and I think the waiting time for that is similarly long. Now, for some people, that's a really, really, really long and traumatic, difficult time to put up with. And so you find there's quite a high rate of people seeking help and seeking clinical help elsewhere, either through online services offered by clinicians in different countries, or through private clinics running in the same country, or through self-seeking their own chemicals, essentially. And you can find that people are relatively adept at getting hold of steroid hormones and other forms of drugs quite easily online. In fact, you can get them from pharmacies in other countries and have them posted directly to your front door. Unfortunately, though, often the information that they've accessed to inform that is not necessarily clinically sound. And there's a lot of peer support through forums and online groups. And it's wonderful that they do support each other, but they're not necessarily drawing on the most up-to-date evidence or best practice clinical guidelines. And so sometimes you do get patients coming to you on strange combinations of things that you can't necessarily agree with or support, not because you don't support their transition, but because that is bad for their liver, or that increases their risk of blood clots. And so sometimes there's a conversation needed about supporting them, but supporting them in a way that to be more safe. And that can take a few consultations. It's obviously the GP consultation is only about 10 minutes long, so you can't often fit much of that in there. And you wouldn't necessarily want to jump in on the first consultation with, right, let's change everything, because you've got to build trust and help them realize that you are there to help them too. Now, in the UK, the General Medical Council, who give me my license to practice, they provide something called guidance for bridging prescriptions. Bridging prescription guidance allows us as GPs, as non-specialists, to prescribe specialist treatment whilst we're waiting for the specialist input to come online through that 4-year waiting period. There are specific criteria that have to be met, and we are still scrutinised as to what we do and how we do it. Other things to be mindful of, though, when somebody does wish to transition, as well as making social and medical transitions, some people make logistical transitions, such as through administrative changes, changing their name or their gender marker on their notes. Now, in England, everybody has a unique patient identifier called their NHS number, which they're given at birth, and that follows them throughout their life, unless they apply for a new one. Now, NHS numbers are gendered. Whether they end in an odd or an even number determines whether it is a male or female NHS number. And that is linked to national programs for recall into cancer screening programs, such as cervical cytology and breast mammography. So if somebody applies for a new medical record and a new NHS number, they lose their invitation, their automatic invite into these cancer screening programs. And even if they've had surgery, there's still sometimes risk associated with certain tissues. So there's an emphasis on whoever is looking after that patient. In my case, it would be me and my GP surgery. There's an emphasis on us putting together a manual database where we are based on what tissues somebody has, so that we can manually invite them into those screening programs. Anything that we do in general practice tends to involve a little bit of lifestyle medicine, working out what people's lifestyle habits are and whether some of them could be modified to improve their health. And in reference to transgender care, an important consideration is smoking, because we know that smoking interacts with estrogen and massively increases somebody's risk of deep vein thrombosis, so clots in the legs, which can break off and cause clots in the lungs. So if we do meet a patient who is taking or wants to start taking estrogen, we need to have that conversation with them about stopping smoking as safely and as quickly as possible. And then also thinking about their sexual well-being. We know that despite taking certain hormones that may stop somebody's periods, for example, that individual could still be fertile and could still ovulate, release an egg that could become fertilized and result in a pregnancy. And so if that does happen, or if they are in a relationship where that could happen, it's important not to make any assumptions about what sort of relationship anybody's in. It's important that we're there ready to provide information about contraception if they wish to know about it. I mentioned microaggressions earlier on, and another thing that's considered a microaggression, although to me it feels a bit more than micro, is this concept of dead naming. And that's when, usually referring to a trans person, but not always, we call somebody by their previously used name rather than the name they've introduced themselves to you as. Now, the risk when we do that with trans people is that this could potentially disclose or allude to their trans status. If we've come into that information, that knowledge, through our position of privilege, being their clinician, and we disclose that to somebody and it's not relevant to their care or our job, then we are breaking the Gender Recognition Act of 2004 and could be found guilty of committing a legal offence. So it's really important for us to keep in mind what name somebody does choose to introduce themselves to you as, and to use that and be respectful. The next case I'm going to introduce you to is PASH. Now, PASH identifies as polyamorous and pansexual. They are also non-binary, like me. PASH was assigned female at birth, non-binary now. Polyamorous and pansexuality, those terms mean different things to different people, but essentially polyamory is when you can have intimate relationships with more than one person. Sometimes they're of a slightly different flavour or nature, meeting different needs. Sometimes they're all very similar and quite egalitarian. It's very different for different people. Pansexual usually means that the individual is attracted to people based on their personality rather than their genitals and what gender they are. And so you may find that somebody who identifies as pansexual enjoys intimate relationships with men, women, people assigned male at birth, but who are now non-binary or trans female, and so on and so forth. PASH is particularly concerned because they have sex with multiple people, some of whom are in the trans community. I get it wrong all the time as well, sometimes myself. So PASH comes to you concerned that there might be a greater risk of HIV. And that isn't a misplaced concern. The transgender community does have a greater rate of undiagnosed HIV. And so they are worried about protecting themselves. Now, there's a couple of different things to bear in mind when we're talking about HIV prevention. One is treatment as prevention. Now, somebody who's taking effective treatment for their HIV, who is undetectable. So their viral load of HIV circulating in their blood is so low, the machines can't detect it. If their treatment is that good that that's the case for at least 6 months, then we know that that person cannot transmit HIV through sexual contact. So U equals U. Undetectable is untransmissible. And that counts as treatment as prevention. And then the other form of prevention to be aware of is something called PrEP, pre-exposure prophylaxis. In England now, that is made available on the NHS. It didn't used to be, and it took a very long time for that to be the case. It's a single tablet, something called Truvada, which is 2 drugs used to disable intracellular mechanisms that help the virus replicate its RNA, which is like the genetic code. And there are 2 different ways of taking it. It's only licensed to take it 1 tablet every single day. But for some people, they can use what's called event-based dosing. Now, this was especially relevant when it wasn't made available freely on the NHS, when people were having to buy it. It was about 60 quid for a month's supply from Singapore. And so to make it last longer, a lot more people were using event-based dosing, which is where you take 2 tablets 2 to 24 hours before sexual contact, and then 1 tablet a day for at least 2 days thereafter. Importantly, though, that only works for people with penile tissue. And that is because this drug has to reach the right concentrations within cells in order to disable that intracellular mechanism that helps the cell replicate its genetic material. And it takes up to 7 days for the drug to reach therapeutic concentrations within vaginal tract tissue. So it's important that although PASH might be familiar with event-based dosing and their friends might be on it, it's important that PASH is made aware that because they were assigned female at birth, they need to take it every single day. Bear with me. There we go. And our last case now is Lex. So Lex identifies as male, was assigned male at birth, and is in his late teens. Doesn't tend to consult very frequently, but comes to you after quite a while of suffering with pain and bleeding from their back passage. And part of the reason for the delay is they've been so torn up and embarrassed about it, thinking that we're just going to blame them and say, well, what do you expect? They do engage in receptive anal sex, and so they feel that that is the cause and therefore they are to blame. It's important when thinking about sexual practices that there's quite a lot of different nomenclature and sort of vocabulary involved. Penetrative versus non-penetrative sex, safe or safer sex versus unsafe or less safe sex. It's important to bear in mind when we use the term safe sex, we're still often referring to archaic notions of whether a condom was used or not. And we know that condom use isn't necessarily in and of itself safe sex. It may be safer if it's used appropriately, but they're often not. The term safer sex, though, is more inclusive and refers to the practice of mitigating any risk, either through knowledge, having a conversation with your sexual partner. Are they HIV positive? Are they detectable or undetectable? Are they on PrEP? Are you on PrEP? All of those sorts of things will inform a decision that is more or less safe in relation to that sexual encounter. Now, sex can be, as I say, penetrative, which could involve the mouth, the anus, the vagina, or all of the above, or non-penetrative. And that can often involve things called frottage, which is just erotic, essentially rubbing body contact. When penetrative sex is engaged with, that can either be as a top, bottom, or versatile individual. Top is the insertive or active role. Bottom is referred to the receptive or passive role. And verse refers to people who occupy both roles, sometimes all within the same sort of encounter. Penetrative sex doesn't have to involve body parts, though, and can involve toys of varying sizes. And when it does involve body parts, it doesn't have to just be limited to the phallus or the penis, and can involve all sorts of other body parts, such as hands and feet as well. The important thing is, no matter how big any of these body parts or toys are, it shouldn't hurt and it shouldn't result in bleeding. Similarly to vaginal tissue, the rectal tissue can stretch and it can self-lubricate through mucus production, and it should result in a pleasurable encounter rather than a traumatic one. So if something does result in bleeding or tearing, it should always make you question whether there was consent, whether there was undue force applied, or things like that. Sadly, there's a much greater rate of that within the queer community, so it's a significant concern to be wary of. Being mindful of time, because I've been waffling on at you for a while now, I'm just going to introduce the concept of active bystanding and allyship. Active bystanding is the practice of disrupting or trying to repair a situation where you see somebody on the receiving end of a micro or macro aggression based on a othered group membership. Now, sometimes that does involve direct action, stepping in at that moment in time, but sometimes it doesn't, and that might not feel psychologically or physically safe for you. And it's really important that you don't do anything that you might feel uncomfortable with or might make you feel unsafe or the other person feel unsafe. So sometimes it means letting that play out, but later on going up, offering them a hug or seeing if they're okay, or if there's anything that you can do to support them after the fact. The important thing is that being an ally doesn't mean always jumping in. One of the first important steps of allyship is examining your own positionality and working out where you're coming from. What sort of things have shaped your experience of life and shaped your understanding of your experience and other people's experience as well. And I think in the next slide, oh brilliant, yes, I do have this analogy of a street lamp or a torch. Sometimes when people refer to being privileged, it can feel a bit pointed and a bit weaponized. And it's certainly not intended, especially when I talk about privilege in that way at all, but it's a term that is used to refer to the unique set of sort of filters that we've all grown up with because of what we've experienced, what we've learned about, how we've seen life and what we've had and what we've gone through. We only see what we shine a light on, and there are naturally things that we don't shine a light on. There are blind spots or otherwise in darkness. But we can learn to shine a light on things that we're not familiar with through connecting with people, listening to their stories, learning about their lived experience, learning about different ways of perceiving things through engaging with culture and art. And a good example is some films that help illustrate the lived experience of people from the queer community. If you're looking for a good Friday night film, I can highly recommend the one called Pride with Imelda Staunton in it, not least because I absolutely adore Imelda Staunton, but it's a really, really helpful film in terms of illustrating some of the within family struggles that some people go through. And I think, oh no, not quite it, nearly there though. When we are in our practices, and I do urge you, if you go into a GP surgery and you see stuff that you think, hang on a minute, that's rubbish, it doesn't reflect the community that this surgery serves. It's one of the first things I did when I joined my surgery about 5 years ago, was go around the waiting room, pulling this down, pulling that down, saying, come on, this is from the 1980s, it's rubbish. Got to update things. Is how our environments reinforcing implicit notions of normality, and how could or should they be changed? And as I've mentioned, within allyship, there are the active bystanding skills that we might wish to develop or draw on, but perhaps most importantly is reflecting on our positionality and our privilege, and use our privilege to help support those whose voice either isn't heard or ignored. And that's it. Oh, and here's a little picture of the film Pride, because I'm a massive fan. So I'll make sure that all of the links and everything for further resources and information are shared when you get the slides. I hope that that's been interesting for you. And I believe we've got a bit of time for questions now.